8. Mounting evidence of post-vaccination mortality. A mortality peak in October 2020 during influenza vaccine rollouts. Many European countries experienced a strong and early peak of mortality in October 2020. This was observed everywhere with a few exceptions: Cyprus, Malta, Denmark, Ireland, Norway, and Finland. The fact that the increases in deaths happened exactly at the same time in the countries concerned makes it impossible to blame it on a single virus spreading from country to country in Europe. Moreover, the widespread use of masks, social distancing measures, the closure of many public places, crowd restrictions in stores, the abundance of hand sanitizer, and the promotion of teleworking have by no means prevented winter mortality from reaching the same levels, if not slightly higher, as what is usually observed, which serves as further evidence that mortality is not related to a propagation phenomenon. However, mortality is occurring far too early considering the onset of the cold season, figure 75. Why, by the end of 2020, did the citizens of a majority of European countries appear to be in worse health than in previous years? The stressful events faced throughout the year, and the lack of outdoor activities might have weakened people's immune defenses. In France, however, as in most other European countries, a major flu vaccination campaign took place starting in October 2020. The vaccination coverage rate even increased by almost 10 points compared to the previous year's 174. The flu vaccination campaign always arrives late in the year, concurrent with the winter mortality increase, figure 56. Figure 56. Flu vaccinations eligible for reimbursement by the healthcare system, distributed in pharmacies. The actual usefulness of the flu shot in relation with winter mortality is debated, even amongst the most ardent proponents of vaccination. It is important to note that this vaccine is not designed like others. It combines several strains of influenza viruses as recommended by the WHO. When the WHO makes its recommendations, there is no certainty about which strains will be identified by laboratories during the winter. It is merely a gamble. Countries like Norway or Finland tend to vaccinate less against the flu, especially since the H1N1 vaccination scandal, see Chapter 9. However, it appears that, despite this, they did not experience winter mortality peaks in previous years. We observe a stark contrast between Finland, figure 57, and Italy, figure 58, in this regard. The data on the distribution of flu shots in France is only available monthly, which doesn't allow for a high-quality correlation with the number of deaths. When examining the population of individuals over 60 years old in France, who are most vaccinated against the flu due to its free availability, the weekly trend in the number of vaccines distributed to them, estimated by smoothing the monthly data, closely precedes the trend in the number of deaths from all causes. This pattern occurs every winter, figure 59. Figure 57, weekly deaths in Finland, standardization according to 2020. Figure 58, weekly deaths in Italy, standardization according to 2020. Figure 59, weekly deaths in France, standardization according to 2020 based on the number of distributed vaccines. The sudden rise in deaths in October 2020 is similar to that observed in previous years, in terms of timing and proportions, but on a larger scale. Even though correlation does not imply causation, the fact that suspicions exist regarding a potential connection between vaccines and the rise in mortality should prompt a comprehensive investigation. It would be beneficial to examine data since 2015, comparing the dates of individuals' deaths with their vaccination dates. Is there a statistical connection between these two timelines? Precise and nominative data for all French citizens are publicly available online. Researchers with authorized access to vaccination data should be able to carry out this investigation. This straightforward research would help dispel doubts if they prove unfounded. It's also odd that no such studies seem to exist for any vaccination, even in childhood, despite the fact that mortality rates are higher in the early years, up to the age of 5, then later in childhood. The relationship between vaccinations and the rise in the number of illnesses has already been studied. The American researcher Greg Wolf published a paper in January 2020 175, showing statistical links between the flu vaccination and an increase in the number of illnesses from other diseases, particularly common colds, for which viral sequence research has revealed the presence of sequences related to coronaviruses. Considering that during the winter of 2019 to 2020, the mortality attributed to the flu was close to zero, the launch of an unprecedented vaccination campaign in October 2020 against a disease that doesn't seem to claim any more victims appears rather puzzling. The impacts of the NOSPO 176 effect alone should prompt a debate on the advisability of a large-scale flu vaccination operation in the context of an openly declared war against a coronavirus deserves to be seriously addressed. The NOSPO effect, the negative counterpart of the placebo effect, involves patients fearing the side effects of a treatment. In the case of the flu vaccine, considering that each patient has, in principle, been informed about possible adverse effects, and that these effects, and their high frequency, are thoroughly detailed in the instructions and in the Vital 177 pharmaceutical dictionary available online, the NOSPO effect can, of course, exist. We previously discussed how there was an underuse of antibiotics and an overuse of palliative solutions like Rivotril and Valium in late 2020. Similar to what occurred in spring 2020, the entire increase in mortality during the winter period, both in hospitals and nursing homes, was attributed to COVID-19. Once hospital events related to COVID-19 started being recorded and counted, flu-like syndromes vanished from the statistics, as evidenced by the Sentinels network. Figure 20. Can we attribute, as the press does, the sharp increase in mortality from October onward to the spread of one single virus? Or is it the result of a combination of three factors: the cyclical worsening of the elderly population's health, measures promoting early outbreaks of winter diseases that were previously referred to as common cold or flu, including the infamous flu vaccination, and the degradation of the healthcare system? According to the Vital Drug Dictionary, administering flu vaccines can trigger diseases, called adverse effects, in elderly individuals, which exhibit symptoms similar to those of COVID-19, i.e. fatigue, fever, headache, and sometimes cough, sore throat, and diarrhea. Some vaccinated against the flu may carry coronavirus sequences, as noted in G. Wolf's study mentioned earlier, leading to positive COVID tests. Unlike previous years, these individuals will not receive the usual medical care, either in general practice or at hospitals, and they won't be prescribed antibiotics since it can't be treated. Many will go directly into palliative care. This protocol has already demonstrated its results in March 2020, and there's no reason to expect different outcomes in October. The new rise in mortality is, like the previous one, primarily due to panic and a denial of medical care. Inequalities exist between regions, and even between households. In richer regions, where populations are known to widely accept vaccination, the increase in mortality is high, whereas in other, less affluent areas, such increases are not observed. 178. For example, in France, there is no excess mortality in October, November for individuals aged 90 and older in Saint Denis, figure 60, unlike what is observed in Marne, figure 61. Should we be surprised to observe an increase in mortality again if the chosen strategy is to organize mass vaccinations that will exhaust patients, especially the elderly, just before the winter periods of increased mortality? Consider that every acute respiratory infection comes from the COVID-19 virus. Assert that there is no treatment, and forbid the prescription of antibiotics. Use palliative care that will shorten the patient's lives. Figure 60, mortality rate for people aged 90 and older, as observed and predicted, with temperature for Saint, Denis B. An alarming pharmacovigilance since the beginning of the vaccine rollout on June 24, 2021, the journal Vaccines published an article titled The Safety of COVID-19 Vaccinations, We Should Rethink the Policy by two Dutch researchers Harold Walich, Rainer J. Clement and Wouter Ockema 179. Figure 61, mortality rate for people aged 90 and older, as observed and predicted, with temperature for Saint, et. Marne. This article was retracted on July 2, 2021 due to the numerous controversies it sparked. The controversy revolved around the methodology used and the data. I cannot help but be concerned given the enormous pressure placed on scientific articles that question the current policy, while other articles with poor data and unscientific methodology receive total leniency as long as their conclusions align with the accepted narrative. To assess vaccine safety, Walich et al. Use a set of data we are about to discuss. The study also references the results of the Dagon et al. Study on the vaccine's potential effectiveness, a study whose numerous biases we discussed in Chapter 7. The idea behind this work is, of course, to juxtapose the two results in an attempt to assess whether the benefits of vaccination outweigh the risks. When launching a policy of this magnitude, it is essential to provide sufficient evidence that the number of lives tragically lost will indeed be significantly lower than that of saved lives. The Dutch study concludes that the number of lives saved per 100,000 vaccinated individuals appears to be quite low, while the number of adverse events recorded by the pharmacovigilance per 100,000 vaccinated individuals is significant. In other words, from the very beginning of the vaccine rollout, and despite an obvious overestimation of the number of lives saved, the authors conclude that the risk-benefit ratio does not justify a general vaccination campaign. Lives lost due to vaccination policy, the glaring lack of organization for effective data reporting. The adverse reactions to medical interventions are recorded at the European level, and available on Vigilance 180. Sections related to COVID-19 vaccines can be found under the letter CS for COVID-19. Reports have been available since the beginning of the vaccine rollout for Moderna, Pfizer, AstraZeneca, and Janssen. Data on Novavax has been available since April 2022. The primary value of Walich et al. S study is to raise concern about the poor reporting of pharmacovigilance data concerning these vaccines. As of July 4, 2021, significant differences exist between countries, regardless of the population size. As highlighted in the study, it would make little sense to conclude that the Dutch have a particular sensitivity to vaccination. The most probable explanation is, of course, that reporting practices vary widely among countries. In general, pharmacovigilance does not adequately track the relationship between the administration of a product and the subsequent mortality. Firstly, pharmacovigilance is organized in a passive way. Agencies wait for individuals, e.g. patients, healthcare professionals, to report cases, government or manufacturers' pharmacovigilance. However, it is well known that passive surveillance is inefficient, and that reports on side effects are much rarer than the side effects themselves, a phenomenon known as underreporting. Studies on the subject 181 estimate that only between 1% and 10% of adverse events are actually reported, meaning that 90 to 99% of them are not. Moreover, the causality assessment method 182 used does not make it possible to connect the death of a patient to the administration of the vaccine. This method relies on the challenge, de-challenge, re-challenge, CDR, principle. A relation between the product and the adverse event is said to be identified when the event occurred after taking the product, e.g. a skin rash, stopped after discontinuing the use of the product, and of the skin rash, and reoccurred when resuming the use of the product, new skin rash. In the present case, the death of an individual aged under 40 following the first dose of the vaccine can only be categorized as challenge. It is not possible to revive the dead, inject them with a second dose, and verify whether they die again. According to this method, a death would be coded as inconclusive. One can also be surprised that out of the 665,525 reports of pharmacovigilance on COVID-19 vaccines, only 266,221, 40%, were submitted by healthcare professionals. Thus, the majority of adverse effects reporting relies on patients who must go through the prescribed, cumbersome, and complex process. It illustrates the poor organization of the monitoring and explains the significant level of underreporting. It also seems unrealistic to assume that minor inconveniences for healthy individuals, such as intense fatigue, would be thoroughly reported, when they can have dramatic consequences for older and frail patients. It is worth noting that if a healthcare professional does not declare a death occurring after taking a medication, there is little chance the deceased patients will do so themselves. The family could do it, but few have the energy in the midst of their grief. Therefore, pharmacovigilance monitoring provides only a partial view of the situation and cannot cover the full spectrum of adverse events. It appears legitimate and logical to try to understand what is happening, by studying the data available in a country that has the most efficient side effects reporting system, the Netherlands. Of course, the study is not perfect as the reports do not perfectly correspond to the adverse events that can actually be attributed to the vaccines. While many reports are missing, we also know that some reports are not related to the vaccine. The study uses pharmacovigilance data not by equating them with adverse effects actually caused by the vaccines but because they are the only known data available. We discussed the lack of reporting, and we know that some of the reported side effects are not related to the vaccines, which we will refer to as over-reporting. The experts overseeing pharmacovigilance are responsible for limiting over-reporting by verifying each report. This part is, therefore, limited. Conversely, no proactive efforts are made to recover underreporting. By design, studying pharmacovigilance data is more likely to lead to an underestimation of side effects than an overestimation. We can only deplore the rigidity of the tool provided by Vigilance. All the charts and graphs are frozen, and users cannot choose their own parameters and cross-compare them for analysis. Considering that there are no technical obstacles to implementing this feature today, this must be a deliberate choice. The quality of the analyses is limited by the tool and falls far short of what should be achievable. Nonetheless, it would be essential to investigate whether the differences observed between countries, types of vaccines, age groups, types of side effects, or other factors are related or independent. In the Netherlands, citizens report the adverse events themselves. LaRev 183 is a website that enables the monitoring of drug safety surveillance reports in the Netherlands. It is immediately noticeable that this country has so many pharmacovigilance reports thanks to patients, not healthcare professionals. More than 90% of them originate from patients. The only way to track the side effects of a treatment is to involve all citizens in the process, rather than relying on a centralized organization that seems to be shirking this responsibility. As discussed earlier, this 90% ratio of escalations made by the patients casts a doubt on how exhaustively the cases are recorded, deaths in particular. As of July 4, 2021, the number of reported deaths in the Netherlands stands at 409 for 13.4 million vaccines distributed, that is 3.05 deaths per 100,000 doses. This ratio is lower than what was cited in the Wallich et al. article. This is partly because vaccination increasingly involved younger individuals over time, who have a very low likelihood of death. Additionally, New vaccinations were administered in late spring, a period when mortality tends to decrease. In Holland, the number of all-cause deaths among people over 65 increased slightly from March 2021, as the vaccine campaign intensified, figure 62. This rebound is difficult to notice for those aged over 80, who are highly sensitive to increases in winter mortality, but it is significant for the age group between 70 and 79 years old. Therefore, there is a statistical link between the vaccination campaign and the increase in deaths. Studying drug safety reports is a valid approach to assess this connection. Figure 62, standardized weekly deaths in the Netherlands. Due to the biases presented earlier, the ratio of 3 deaths per 100,000 vaccinations is not the exact reality but merely the best approximation we have today. In the Whalage et al. Study, the ratio was 4 per 100,000, at a moment when winter and the number of elderly individuals had a stronger influence. Since the start of the vaccine rollout, alerts about cases of deaths have been raised, with no other consequences than censorship. This goes against what usually happens. In recent history, several vaccine products have been withdrawn after the reporting of a much lower number of side effects, detailed further below. All pharmacovigilance data is alarming. Written in collaboration with Catherine Thielhead, PL/SQL and Relational Database. Management System Programmer, retired from the City of Paris retirement. As time passed, the list of side effects made by European pharmacovigilance services only went worsening. Despite the reluctance of many healthcare professionals to report adverse effects, the numbers are staggering. In France, periodic surveys are conducted based on reports made to the ANSM. As of June 9, 2022, over 107,000 adverse events had been reported for the Pfizer vaccine alone. 184. More than 27,000 are considered serious and 1,500 resulted in the death of the patient. The ANSM only communicates fragmented and incomplete information and does not give direct access to official data. Investigative work by independent researchers is currently impossible. In Europe, more than 300,000 post-vaccination adverse events have been reported since the beginning of the vaccine rollout up to June 17, 2022, out of which 28,000 are cases of death, figure 63. The European Medicines Agency, EMA, communicates more detailed information, and most importantly, gives access to source data, even though they are incomplete, e.g. vaccination or death dates, which would allow to assess how long it took for the adverse event to occur, are missing. There is no mention of the batch numbers either. Figure 63, European pharmacovigilance data. As of June 17, 2022, we have noticed a strange phenomenon since these investigations on the adverse effects of the COVID vaccines started in Europe. Over about 10 months, more than 5,000 cases of resurrection have been observed. Basically, some patients were declared dead due to vaccination-related causes, before disappearing from the records. Some of them, less than 1,000, subsequently reappeared in the death records. It is hard to believe that so many mistakes could have been made during the reporting of such serious adverse effects, a true ordeal for the reporter, especially considering that deaths are more often declared by healthcare professionals. In the United States, the situation is the same. The Vaccine Adverse Reporting System, VAERS, offers a very transparent access to all the vaccine's adverse effects reported since 1990-185. In 30 years of vaccinations other than COVID-19 vaccines, 11,000 post-vaccination events followed by the patient's death were reported to the U.S. Vaccine Pharmacovigilance. In only 2 years, and for the COVID-19 vaccines alone, 16,000 post-vaccination events followed by the patient's death have been reported, figure 120. These events concerned 11,500 deceased individuals, Pharmacovigilance counts the effects, and since each patient can experience multiple effects, it is important to also count the number of individuals affected. The silence surrounding these staggering figures is astounding. In the past, 2 vaccination campaigns were stopped long before reaching the dizzying figures of adverse effects from COVID-19 vaccination. From October 1 to December 16, 1976, 48 million U.S. citizens were vaccinated against the influenza A virus, swine flu, H1N1, under Gerald Ford's presidency. 3 months later, with 532 cases of Guillain-Barré syndrome and 25 deaths, the campaign was abandoned. 186. In 2019, the government or the Philippines decided to stop the vaccination program against dengue using Sanofi's Dengvaxia, after 14 people died out of nearly 1 million injections over 2 years. 187. Figure 64, number of events followed by the death of the patients, declared each year to the U.S. vaccine pharmacovigilance. In comparison, in just a year and a half of COVID-19 vaccination, we are approaching 40,000 officially reported deaths across Europe and the U.S. Until now, only a few dozen deaths were enough to put an end to a vaccine rollout. And there are still the multiplier factors needed to approach reality. According to the Berlin Declaration on Pharmacovigilance 188, only 2 to 5% of adverse effects are actually reported, according to the LEEM, French Trade Union of Pharmaceutical Companies. The proportion varies from 5 to 10%. 189. Consequently, even by only considering 3/4 of the recorded deaths, that is 30,000, to account for potential attribution errors and thus over-reporting, and by applying the most favorable vaccine reporting rate of 10% as mentioned by the pharmaceutical companies, we still get the colossal number of 300,000 deaths. C. Mass vaccination pioneer Israel quickly showed an increase in mortality among young people in summer 2021, Dr. A. Hen Ryan, COD and Dr. S. Ohana contacted me as part of a study on mortality in Israel, where alarming signs of excess mortality among young people had appeared. We discussed statistical methods for comparing mortality over a long period of time, in particular age, standardist deaths. Their goal was to rapidly publish a study to alert the authorities. The study 190, like any study in disagreement with the pro-vaccine propaganda, was censored by Dr. Ohana's usual hosting platform and was never published. In September 2021, I wrote an article under a pseudonym, using all available data from Israel and recalculating the figures in an attempt to raise awareness in France. My article was published in the newspaper François, but the only reaction it triggered was another fact-checking article, written by a small internet media outlet known for its critical stance. To write this article, I downloaded all data available online from the Israeli Office of Statistics. All my calculations and graphs can be transparently consulted. 191. No possible justification for the health measures in Israel either, just like the overwhelming majority of Western countries. Israel's population has been steadily increasing and aging. At the beginning of 2021, approximately 3,300 people were dying each month. This average has been increasing regularly, and reached more than 4,000 by mid-2021. More than 85% of these deaths concern people over 60 years old. Given I was assessing the impact of COVID-19 and the vaccination campaign, I excluded all the deaths that occurred on April 30, 2021, to avoid counting the victims of the Mount Meron tragedy. 192. Figure 65, H. Standardist deaths in Israel according to the population as of January 1, 2021. If we adjust the changes in mortality for population and age pyramid, by calculating standardist deaths, the recent mortality situation in Israel is absolutely normal. Figure 65. Note, this graph represents the monthly all-cause mortality, scaled to a 30-day period, and standardized based on the population as of January 2021. For example, over a 30-day period, 5,304 people died in Israel in January 2021. By standardizing the population as of January 2017 according to the population as of January 2021, there would have been 5,374 deaths in January 2017. As any other in the Northern Hemisphere, Israel experiences higher mortality rates in winter. The winter increases in mortality in Northern Hemisphere countries occur simultaneously, and only affect individuals over 50 years of age, and not the youth. The mortality rate among young individuals is not constant, it is actually so low that the slightest event can make it vary. Conversely, the mortality of the elderly is so important it stabilizes the statistics. Their high winter mortality is clearly visible and exceeds all external influences. Our age-specific analyses of the Israeli statistics only focus on individuals over 19 years of age. Firstly, because at the beginning of 2021, very few people under 19 had been vaccinated. Secondly, and more importantly, because the mortality of the 0 to 19 age group is primarily influenced by the mortality of babies in their first year of life, 0 year. In every developed country, infant mortality is by far the highest until the mortality of older age groups surpasses it. The number of births influences the death rate in this very first age group, much more than any external event. And we do not have data by age group that distinguish under 1 year old from other ages until 19. As seen in Chapter 5, there is no such thing as a propagation of winter excess mortality waves. The rise in the number of deaths does not originate from something that transmits from one individual to another on a global scale. Increases in mortality in Sweden, Portugal, and Israel occur simultaneously. However, depending on the year, winter excess mortality in the Northern Hemisphere can occur with a delay of several weeks or even months. As demonstrated earlier, it appears to depend on weather conditions. To encompass the entire winter time, I compare years from July to June, Figure 123. Figure 66, standardized deaths in Israel from July to June, based on population as of January 1, 2021. Note, assuming that the population of Israel remained constant between July 2020 and June 2021 at the level of January 2021, we count 49,979 deaths over the period. By adjusting the population of Israel between July 2017 and June 2018 to the population as it was in January 2021, 50,195 deaths are counted over the period. Despite the announcement of worldwide devastation due to COVID-19 in March, April 2020, the Israeli statistics show that the period from July 2019 to June 2020 corresponds to an all-time under mortality. The following year, from July 2020 to June 2021, mortality remained relatively low compared to the decade. This result is similar to what can be observed in every country in Europe where data is available. Consequently, over 2 years, from July 2019 to June 2021, no significant increase in the number of deaths can be observed in Israel. Some deaths over these 2 years were attributed to COVID-19, without resulting in an unusual rise in their number, Figure 67. Figure 67, number of daily deaths in Israel, all causes, and those reported as COVID-19. In the past, winter increases in mortality were attributed to influenza viruses. Today, it is the coronavirus. The coding principle detailed in Chapter 4 for France applies to every country following the guidelines of the WHO. In Israel, as in European countries, none of the restrictive policies that were implemented can be justified by an exceptional increase in mortality caused by a deadly virus. There was no carnage. Mortality during the vaccine rollout, perfect correlations in Israel. We observed two distinct periods of increasing mortality during the winter of 2020 to 2021, the first in October, the second in January. The increase in deaths in October occurred simultaneously in every country that massively vaccinated against the flu. See beginning of this chapter. In France, with access to data on medication dispensing, we can notice that the almost perfect proportionality between the number of injections and the increase in mortality. In Israel, the Ministry of Health also promotes these injections 193, in particular for individuals over 65 years of age. Figure 68, monthly number of deaths in Israel. By age group, the increasing number of deaths shows distinctly starting from the 70 to 79 years old age group, figure 68. In fact, October 2020 is the only month during which standardist mortality in Israel differs from what is usually observed. The rest of the period is comparable to the past decade. We cannot delve further into the analysis due to a lack of access to the number of flu vaccinations administered in this country. We can only conclude that a perfectly synchronized correlation exists for all the countries that massively vaccinated against the flu. Countries more reluctant to administer these injections, such as Finland, did not experience this increase in mortality in October. Regarding the COVID-19 injections, we find strong correlations for each age group between the number of vaccines administered and the death rates, figure 69. All age groups experienced an increase in mortality during the months of vaccinations. The elderly were massively vaccinated in January and their age group experienced a spike in mortality in the same month. The younger age groups received their injections a bit later, and experienced a mortality peak in February. This time delay in mortality synchronized with the injections provides further evidence of a potential link between the injections and the increases in mortality. Since individuals over 60 years of age were vaccinated in the midst of winter, in January, it is challenging to ascertain a potential vaccine-related cause. For modeling enthusiasts, representing the death rate as a function of the vaccination rate yields a nearly perfect logarithmic correlation, with an R superscript 2 value of 0.95, based on the monthly number of deaths occurring 5 days following vaccinations. It took much less for the researchers who published the article praising the merits of lockdowns, conveniently forgetting that mortality naturally decreases in spring, regardless of any lockdown measure, Chapter 5. It is as if we were using this perfect correlation to prove that in winter 2020 to 2021, the mortality of individuals over 60 years old was only to be attributed to the vaccines, all the while disregarding the impact of the winter season. Figure 69, number of vaccines administered and death rate per 100,000. By age group, however, the excess mortality observed in the 20 to 49 age group has a different cause because this category of the population does not experience excess mortality in winter. This age group enables to better measure a potential post-vaccination mortality. This does not mean that it does not exist for other age categories, but for older individuals, it is overshadowed by the usual winter excess mortality. The age group of 20 to 29 years old experienced an exceptional mortality during the vaccination rollout in Israel, figure 70, with 2 peaks exceeding the usual standard deviation in February and in April. Moreover, the mortality rate remained above average for 3 months. The only time a higher mortality rate was observed was during the 2014 war. Figure 70, standardist mortality of the 20 to 29 years old in Israel since 2011 in total, this excess mortality between February and April 2021, i.e. The number of deaths is above the 95% confidence interval of what is observed over a cumulative 3-month period, corresponds to the deaths of 18 young people aged between 20 to 29 years old, 2.3 per 100,000 young individuals who received 2 doses. These 18 deaths affect a population that never experienced COVID-related excess mortality. During this period in early 2021, a university scholar 194 noted that comparing with previous years, the number of calls to the emergency departments for heart failures and acute coronary syndromes drastically increased. This observation was further examined, detailed, modeled, and published in the journal Nature in April 2022. 195. Truth takes the stairs. Despite all this, it did not seem to deter the authorities from continuing and even seeking to expand COVID-19 vaccination. If deaths are only the tip of the iceberg when it comes to health issues, the excess mortality occurring during the mass vaccination of the youth provides an insight into the severity of the situation. In March 2021, the French ANSM acknowledged that post-vaccination pericarditis could occur 196, despite such cases being very rare. It would be interesting to have an explanation of how chance operates for a statistically significant increase in heart problems to occur just after vaccination campaigns. Considering that death is usually the final stage of an individual's health deterioration, it is rare to observe an event that is entirely binary between good health and death. An increase in the number of deaths is likely accompanied by a much larger increase in the number of intermediate situations, such as diseases like strokes, myocarditis, pulmonary embolism, non-lethal thrombosis. Invisible in the study of all-cause mortality, these diseases are reported in pharmacovigilance. The abnormal increase in mortality raises the level of certainty regarding the vaccine-related causality of these non-lethal events. D. Excessive mortality among young people coincides with vaccine campaigns across Europe. Excess mortality is too frequent all across Europe. The Euromomo 197 website, European Mortality Monitoring, provides indicators to track the mortality rates of European countries. Since summer 2021, the number of deaths among Europeans aged 15 to 44 has exceeded the above the average, as calculated by the website, Figure 71. But what could possibly be causing the deaths of the young people since summer 2021? To establish whether a country has experienced more deaths than usual, Euromomo calculates a z-score for each country every week. The z-score is the difference between the observed number of deaths, x, and the expected number of deaths, divided by the distribution standard deviation, sigma. If the z-score is positive, it indicates excess mortality, while if it's negative, it suggests under-mortality. The z-score will be all the more significant when the difference between observed deaths and expected deaths deviates significantly from the usual variances. Figure 71 to 15, 44 years old deaths. As from the Euromomo website note, the curve represents the number of deaths. The shaded area represents the normal range around the dotted line average. The upper dotted line indicates the threshold for significant excess mortality since mid-2021. The z-scores for individuals aged 15 to 44 have often been positive for a large majority of countries. However, in most cases, the curves do not cross the pink dotted line representing abnormal excess mortality. Conversely, at the European level, when the data from countries are aggregated, this crossing is observed. This means that in Europe, a slight over-mortality is observed almost everywhere at the same time. 198. We notice that in 2021, for a majority of European countries, the z-score is seldom negative. In France, for instance, there are only 3 weeks with a negative z-score. Out of the 26 considered areas, 12 have fewer than 9 negative z-scores out of 33 periods, and 3 have more than 24. This situation is exceptional when compared to the same periods in previous years, Figure 72. The conclusion is definitive. According to Euromomo, since summer 2021, there have been too many deaths among the 15 to 44 years old. Figure 72, number of negative Z-scores per year and per country for individuals aged 15 to 44 starting from week 20. A thorough check is required in January 2022. Professor Patrick Meyer, from the University of Leeds, published a preprint 199 that concluded a significant link between the number of injections and excess mortality in many European countries, using machine learning methods. Since I had previously developed programs linking weekly all-cause deaths in European countries with the weekly number of injections, I suggested we could work together on a correlation study. The rest of this chapter is the result of our collaboration, along with Patrick D., an independent Belgian consultant. The three of us worked together to produce the various figures in this chapter. We had many discussions on the statistics presented here. Much of the following information was presented by Professor Meyer at the 46th reunion of the Independent Scientific Committee in March 2022. 200. Thanks to the statistics of Euromomo, we have discovered the existence of an excess mortality among young Europeans since the beginning of the year 2021. But discovering that more people than expected are dying cannot go without verifying the origin of such prevision, especially in the midst of a crisis. For the past years, our institutions, comprised of so-called experts, have been sounding the alarm over the COVID catastrophe, all the while omitting that the population is getting older, and that abnormal increases in mortality actually occur every 2 or 3 years. Since Euromomo doesn't provide the specifics of its Z-score calculation, we've downloaded the data to check if we can replicate the results using different methods. The majority of European countries publish weekly data on mortality 201 and population 202 broken down by age group. Therefore, we can create forecasts for the years 2019, 2020, and 2021 based on data from 2013 to 2018. We have carried out 2 different projections to verify their consistency with each other, and with Euromomo's projection. The age groups are as follows: 15 to 24 years, 25 to 49 years, 50 to 59 years, 60 to 69 years, 70 to 79 years, and those over 80. Like Euromomo, we carry out weekly projections. These projections must necessarily take into account 1. The trend in the evolution of the number of deaths, caused by changes in the age distribution, and possibly by the evolution of mortality rates. 2. The seasonality, more deaths in summer for the young, more deaths in winter for the old. To account for the seasonality of mortality, we will base our projections for each week on data from the corresponding weeks in previous years. For example, the projection for week 10 of 2020 rely on data from weeks 10 from 2013 to 2018. However, the 2 models handle the long-term mortality trend differently. The first model only considers the total weekly number of deaths for each age group. In a linear way, it extends the trend in the number of deaths that was observed between 2013 and 2018, for the years 2019, 2020, and 2021, figure 73. This model assumes that all population and mortality rate trends continue for an additional 3 years. The red curve represents the observed deaths, the gray curve represents the deaths predicted by the model. The period used to build the model is shown in black, while the estimated period appears in violet. Then, it's a matter of calculating the difference between the model and the observed reality to determine whether there is excess mortality or under mortality. With this model, the analysis is clear. Nearly every country has experienced excess mortality among young individuals since summer 2021. For example, when considering all European countries providing data, the graph below illustrates the situation for the 15 to 24 age group. A red bar indicates an increase in mortality, while a green bar suggests a decrease. The blue curve represents the trend over 6 weeks. It clearly shows excess mortality. The second model takes into account the total weekly number of deaths for each age group and incorporates the population within that group for each week. To do so, the model computes age, standardist mortality. It then extends the observed trend in the number of standardist deaths linearly from 2013 to 2018 for the years 2019, 2020, and 2021. This model assumes that changes in the number of deaths from a year to the next are explained by shifts in the age pyramid and by trends in the mortality rates. Using this model, we find the same result: young people are dying at a higher rate than expected, figure 74. Figure 73, Model 1, difference between expected and observed weekly deaths for the 15 to 24 age group in Europe, figure 74. Model 2, difference between expected and observed weekly deaths for the 15 to 24 age group in Europe. Regardless of the model used to estimate the number of expected deaths, whether Euramomo's model or the ones we have just presented, the conclusion remains the same: there are too many deaths among young Europeans since summer 2021. But why? What has happened that's been particularly significant in most European countries since the summer 2021? Simultaneous mortality peaks alongside vaccination campaigns. The European Centre for Disease Prevention and Control, ECDC, website provides a database 203 of the number of vaccines administered in every country, each week, and by age group. It is possible to connect this vaccination data with the mortality data we previously calculated. Many countries and age groups display increases in the number of deaths simultaneously with the vaccine rollout, followed by above average mortality. These increases can be observed both with our first model, raw mortality, as well as the second one, standardist mortality. If the vaccines were causing health problems, we would observe the exact same patterns. Initially, there would be an increase in mortality among individuals who experience a strong adverse reaction to the injection and pass away quickly. Subsequently, we would observe a slightly higher mortality rate than usual among those who became chronically ill after receiving the vaccine, eventually leading to death. Here are a dozen examples, representing various scenarios. The 15 to 24 age group in Portugal and Finland shows excess mortality during the vaccination campaigns, figures 75 and 76. This is particularly pronounced in Portugal, where 98% of young individuals were vaccinated within a very short time span. In Finland, which vaccinated its young population to a lesser proportion, episodes of excess mortality are observed, even though they are not as pronounced. However, they are perfectly synchronized with the vaccination campaigns. Figure 75, excess mortality for the 15 to 24 age group in Portugal, and the number of vaccines administered. Figure 76, excess mortality for the 15 to 24 age group in Finland, and the number of vaccines administered. Figure 77, excess mortality for the 24 to 49 age group in Estonia, and the number of vaccines administered. Figure 78, excess mortality for the 24 to 49 age group in Hungary, and the number of vaccines administered. Figure 79, excess mortality for the 50 to 59 age group in France, and the number of vaccines administered. Figure 80, excess mortality for the 50 to 59 age group in Greece, and the number of vaccines administered for the 25 to 49 age group in Estonia and Hungary. There are also increases in mortality observed during the vaccination period, figures 77 and 78. Hungary was the first country that massively vaccinated its youth. It experienced a rise in mortality very early in the year for the 50 to 59 age group in France and in Greece. Several waves of mortality can be observed since the beginning of the vaccination campaigns, figures 79 and 80. For the 60 to 69 age group in Austria and Croatia, the excess mortality curves almost perfectly mirror the vaccination curves, figures 143 and 144. For the 70 to 79 age group in Poland and Italy, excess mortality occurs in spring, at a moment when winter mortality is supposed to decrease, figures 83 and 84. It appears as if the injections had triggered a new wave of winter mortality. For reference, the excess mortality. Mortality in October 2020 occurred precisely when flu vaccines were administered. Figure 81, excess mortality for the 60 to 69 age group in Austria, and the number of vaccines administered. Figure 82, excess mortality for the 60 to 69 age group in Croatia, and the number of vaccines administered. Figure 83, excess mortality for the 70 to 79 age group in Poland, and the number of vaccines administered. Figure 84, excess mortality for the 70 to 79 age group in Italy, and the number of vaccines administered. Alongside the observation of these correlations on the graphs, we have examined whether a rise in vaccination corresponds to a rise in deaths. The results available online, in a table 204. To do so, we considered the two most significant mortality peaks since the beginning of the vaccine rollout, and we assessed whether they appear within 2 weeks of a peak of vaccination. We thus examined a 5-week interval centered around a peak of vaccination. For example, about 41 weeks have passed since the beginning of the vaccination of the 25 to 49 age group. Hence, there's a 12% chance, 5 out of 41, that the most significant death peak aligns with the first doses peak. There is a 23% chance that either of the two largest death peaks coincides with the first doses peak. Among the 17 studied countries, the proximity of a vaccination peak to a mortality peak is observed in 40% of all cases. This is significantly too much to be a coincidence. The mortality maximums for the young are too often neighboring the maximums of doses 1 and 2. Regarding the eldest, the peak of mortality is too often neighboring the vaccination with dose 3. We are not the only ones noticing these correlations. Researchers Spiro Pantazatos and Hervé Seligman released a preprint 205 highlighting the link between the number of vaccinated individuals and the excess mortality observed in different states of the U.S. Christoph Kabandner's analysis of detailed German data also supports this finding. 206. So many statistics that raise concerns about increased mortality among the population, most likely associated with COVID vaccinations, and yet this seems to go unnoticed in the media. It's worth noting that it was precisely the same kind of statistics that led many people to believe that a virus was responsible for the 2020 increases in mortality in 2020. Many are left questioning the motives of political and health authorities for refusing to investigate post-vaccination mortality from all causes. Who advised the French Senate President's Conference to reject Professor Laurent Tobiana's request to be given access to the data? 207. Is it the same management consulting firm that advised the Ministry of Health on its statistical study choices since the beginning of the crisis? 280. The British data shows higher mortality rates among the vaccinated than among the unvaccinated. Written in collaboration with anonymous scientist Pierre-Yves Covet. To our knowledge, the British Office for Statistics is the only one providing data on all-cause deaths based on vaccination status. 209. The mortality data related to COVID-19 vaccination status are the only one that can help establish whether there's a favorable individual benefit-risk balance. It is important to consider all-cause mortality rather than the sole mortality attributed to COVID-19, for two reasons. The first reason is that such attribution comes with biases that prevent any solid conclusions. Chapter 7. It is clear that if populations are facing a serious threat and if vaccination is effective, then all-cause mortality among the vaccinated should be lower than that among the unvaccinated. The second reason relates to the potential existence of risks. If vaccination is absolutely harmless, but doesn't provide any benefits, then the mortality rates in both groups will be the same, and we can conclude that it is a vaccine scam. The conclusion is nearly the same if vaccination prevents as many deaths as it causes. Finally, if all cause mortality among the vaccinated is higher than that among the non-vaccinated, it raises a very serious concern. All-cause mortality provides another, albeit minimal but quantifiable, approach to evaluating adverse effects, free of any declaration bias. While we genuinely appreciate the Office for National Statistics' release of all-cause mortality tables based on vaccination status, we do have concerns regarding the fact that these are processed data, problematic in many respects, rather than raw data. In the spirit of transparency, it is crucial to also publish the raw data, which would enable independent scientists to verify the calculations made. In their most recent versions, the British files contain 9 tables. These tables indicate the numbers of deaths or the standardist numbers of deaths, ASMR, standardist mortality rated, whose significance we explained in the first chapter of this book. The data is also broken down by age group, which is essential for assessing the relevance of vaccinating the younger population who had never experienced an abnormal increase in mortality until the beginning of the vaccination campaign. Inconsistencies in mortality statistics. Standardist mortality data are available for all COVID-19 vaccination status categories. The theory of vaccine protection, dependent on the number of doses received and the time between the shot and its effectiveness, leads to the multiplication of categories. The 7 different categories of people that received at least one injection, from those who have just received the first dose, to those who received their third dose more than 21 days earlier, are aggregated into an 8th category called ever vaccinated. At first glance, the comparison between the non-vaccinated, unvaccinated, and those who have received at least one dose, ever vaccinated, appears to favor vaccination. Vaccination, showing that vaccinated individuals have a significantly lower mortality rate than the non-vaccinated. However, upon closer examination of the results by vaccine category, we observe strange and dramatic increases in mortality among vaccinated individuals concurrently with the administration of new doses of vaccine. As a reminder, the United Kingdom had a specific vaccination strategy, Figure 85, initially opting to administer a single dose to its entire eligible population starting in January 2021 and only beginning to distribute the second dose from April 2021 onwards. Figure 85, COVID-19 vaccination coverage in the UK in February 2021, as the first doses were widely distributed, mortality among the unvaccinated increased significantly, Figure 86. From May 2021, as the vaccination campaign for the second dose began, mortality among the vaccinated with one dose exploded, greatly exceeding the mortality rates among the unvaccinated, which had stabilized after a significant decrease. In November 2021, as the campaign started for the third dose, mortality among those who had received 2 doses skyrocketed, exceeding that of the other categories by December 2021. Figure 86, standardist all-cause mortality by vaccination status in England. Note, the solid lines represent the standardist all-cause mortality by vaccination status, and the dotted lines represent the confidence intervals provided by the Office for National Statistics. If we consider the sole mortality attributed to COVID-19, the effect of vaccination seems spectacular. During the first months, however, from the autumn of 2021, the COVID-19 mortality rate among those who received 2 doses started to increase to the point of surpassing that of the unvaccinated. Many explanations were brought to justify these observations. It is possible that the most vulnerable among the unvaccinated individuals had already succumbed to the disease, and the survivors may possess a resistance to the illness, either pre-existing or acquired, that is significantly better than the protection offered by the vaccine, as suggested by numerous studies. 210. There could also be a survivorship bias among those who have received 3 vaccine doses, meaning that the most vulnerable individuals might have passed away during the vaccination process. However, the sole fact that the unvaccinated are dying at a lower rate than those who have received 2 doses of the vaccine should have raised questions among health authorities long ago, especially those claiming to seek herd immunity. What is the point of vaccinating individuals who have acquired natural immunity? That could have been a first step to move away from the ongoing vaccination-only frenzy. Things become more unsettling when looking at the evolution of non-COVID mortality. Similar to overall mortality, there is a spike in non-COVID-19 mortality among the unvaccinated during the rollout of the first dose. We also observe a spike in mortality among those who received just 1 dose at the start of the campaign for the second dose, and another increase in mortality among those who received 2 doses when the campaign for the third dose began. British professors Martin Neal and Norman Fenton 211 provide an explanation for the peculiar shape of these curves. Their article suggests that observed deaths according to vaccination status were systematically miscategorized, leading to a delay in counting the numbers. The authors provide a fictional example where the population is vaccinated with a product that has absolutely no effect on mortality. As a result, mortality remains constant and equal for both the vaccinated and the unvaccinated. They then assume that there is a delay of a few days in reporting vaccination status information. This introduces a counting bias where some vaccinated individuals who die are categorized among the unvaccinated due to the reporting delay. This delay may be unintentional and be entirely due to the difficulty of reporting complete data. It may also be intentional, based on the assumption the vaccine has no effect in the initial days and should not be considered under any circumstances. This assumption exactly mirrors the patterns of mortality spikes observed in England. The conclusion would be that for each vaccination campaign, deaths of individuals who have just received a new dose, deaths that may or may not be related to the injection, are mistakenly attributed to the group that received 1 dose less. With such a recording bias, one could show that 1 more dose systematically reduces mortality, since the deaths are assigned to the wrong group. Therefore, the mortality peak among the unvaccinated at the very beginning of the first campaign is only the result of a discrepancy between the numerator and denominator. When computing the mortality rate, the numerator represents the number of deaths, and the denominator the population, all broken down by vaccination status. Let us consider a population of 1,000 people, out of whom 100 get vaccinated every day. Each day, 1 person dies. The mortality rate is 1 in 1,000. But if someone's vaccine status needs 10 days to be validated, then each death will be counted among the unvaccinated. On the first day, the mortality rate among the unvaccinated will be 1 in a 1,000. On the second day, 1 in 900. The following day, it will be 1 in 800, and so on until it reaches 1 in 100 on day 10. Meanwhile, the death rate among the vaccinated will have remained at 0 during the first 9 days, before reaching 1 in 1,000 on day 11. This delay is the best explanation for the strange rises in mortality among the unvaccinated in February 2021, and then among the vaccinated with 1 dose from May 2021, etc. This hypothesis proposed by the English professors to explain the differences in mortality between the 2 groups was confirmed by Swedish researchers who sought access to the data by vaccination status 212. Swedish authorities label individuals who have received injections within the last 15 days in their previous vaccination status, which distorts all analyses on mortality, related to COVID-19 or not. Statistician Jessica Rose 213 assessed the death rates in Sweden, taking into account this recording bias. The result of her study completely overturns the official conclusions. It concludes that the mortality of vaccinated Swedes is 14 times higher than that of the unvaccinated in February 2021, when the official narrative based on the recorded vaccination statuses concludes that the mortality of the vaccinated is 6 times lower than that of the unvaccinated. Incidentally, this brilliant and courageous researcher saw one of her publications, although it was accepted by a journal after being peer-reviewed 214, withdrawn without any scientific explanation to justify this retraction, which is not scientifically acceptable. This article presented a highly interesting analysis of the adverse effects reported in the American Drug Safety Database and addressed the question of causality using the Bradford-Hill criteria. Figure 87, sudden deaths excess among young people aged 18 to 29 in England and COVID vaccination. Despite the significant identified issues that may be attributed to systematic classification errors, what is the actual risk-benefit ratio for young people, knowing they are at lower risk for COVID? Up to now, the Office for National Statistics, ONS, has published 7 data sets between July 2021 and July 2022. These data sets underwent modifications with each publication. The first data set that caught our attention, third version published by the ONS, represented the mortality data until October 2021, figure 151. The youngest age group available ranged from 10 to 59 years old. Consequently, we were able to observe early on that unvaccinated individuals aged 10 to 59 were dying at nearly half the rate, all causes combined, compared to those who had received 2 doses of the vaccine. However, the age group was too broad to conclude anything. The discrepancy could simply be explained by the fact that teenagers, who die at a lower rate than people in their 50s, are more represented in the unvaccinated group than in that of the vaccinated with 2 doses. A few months later, a new version of the data set was released. The youngest age group ranged from 18 to 39 years old, which is better. And again, the all-cause mortality among individuals vaccinated with 2 doses appeared significantly higher than that of the unvaccinated for most of the period. Such data should have led to questioning, if not immediately suspending, the vaccination of young people. Note, the dotted lines correspond to 95% confidence intervals. The data for the unvaccinated appear in light gray on other graphs, to enhance comparability. The most recent version of the data set retained the 18 to 39 age group. We found that data corrections compared to previous versions had removed the significant excess mortality observed among the vaccinated with 2 doses. It is essential to conduct a detailed analysis of what has been altered with access to raw data. Moreover, despite the identified biases that favor vaccines, none of these statistics can justify the vaccination policy towards young people. We find it reasonable to conclude that, given the lack of evidence on the benefit of these vaccines in reducing virus transmission between a vaccinated and an unvaccinated individual, which would have contributed to a collective benefit, these data cannot support the generalist vaccination of young people. On the contrary, although too fragile, these data tend to indicate the unvaccinated have a lower mortality rate, for all causes combined, than the vaccinated. Classification concerns prevent us from drawing a definitive conclusion either way, but they are enough to raise concern. The precautionary principle should have been applied long ago. It is profoundly regrettable that data on all-cause mortality by vaccination status have not been published in France, and even that access to these data has been denied to recognized researchers. These data will play a crucial role to shed light on the actual risk-benefit ratio of vaccination. It is almost unbelievable to witness the amount of work and energy required to determine whether it is reasonable to get vaccinated against COVID-19, especially when you're young or have young loved ones. We are witnessing an unprecedented reversal of the burden of proof. Normally, it is the responsibility of manufacturers to demonstrate that their products have a favorable benefit-risk balance, and not the public's duty to prove otherwise. The Twitter OS account 215, which presents itself as being held by a simple citizen, published an analysis comparing the excess mortality of young English people for cases of sudden deaths and the number of vaccines distributed. This graph, figure 87, represents the weekly excess deaths in England, compared to previous years, in young people between 18 and 29 years of age, attributed to sudden death, codes I-25, I-46, I-49, I-50, I-51, and R-96. We add the number of vaccine doses received by these same young people. The correlation is astonishing. Faith in vaccine safety received the final blow, which probably came in the form of an analysis published in September 2023 216. The British data make it possible to compare for each age group the proportion of vaccinated individuals in the population with that of vaccinated individuals among the deceased. The reasoning is simple: if the vaccine is safe and protects against a fatal disease, then the rate of vaccinated individuals among the deceased must be lower than that of vaccinated individuals in the population. We discover that for all age groups and regardless the number of doses received, the proportion of vaccinated individuals among the deceased is higher than the proportion of vaccinated individuals within the population. According to official English sources, the vaccinated are indeed the ones that are dying too much. F. Governmental agencies are serving the government, not the people. On January 18, 2022, the AP FAIR Group published a new study on COVID-19 vaccines 217. This time, they focused on assessing the risks of myocardial infarction, brain stroke, and pulmonary embolism following vaccination against COVID-19 among adults aged under 75 years old in France. AP FAIR is a scientific interest group created in 2018, claiming to bring an independent expertise on the epidemiology of healthcare products. The displayed independence here pertains to pharmaceutical companies but not the government. Indeed, AP FAIR is under the direct authority of both the ANSM, French National Agency for the Safety of Medicines and Health Products, whose shortcomings were exposed during the Mediator Health scandal, and the CNAM, National Fund for Health Insurance. Consequently, the AP FAIR Group is possibly subject to a double lock. As a reminder, during summer 2021, AP FAIR published 2 studies 218 supporting the COVID-19 vaccination, which they described as extremely effective. We detailed in Chapter 7 how their methodological choices allowed them to find the good results. And during the winter 2021 to 2022, everyone could see just how effective vaccination proved to be. In its new study, AP FAIR seeks to demonstrate the safety of vaccines. Its director repeatedly tweeted that vaccines are safe and effective. The goal now is to prove it. In fact, in order to find results that align with the government's expectations, AP FAIR selectively sorts through the data and chooses a methodology that suits its agenda. We will see that despite these adjustments, AP FAIR highlights significant risks posed by adenovirus vaccines. AP FAIR's study provides no information about young people. Reading its title, one might think the AP FAIR study is representative of young people. It is not the case. Since the observation period ends on July 20, 2021, and the analysis only takes into account events occurring during the 3 first weeks following the first or second injections, this means that only individuals fully vaccinated before June 30, 2021 appear in the data. At that time, only 16% of the 18 to 24 years old, 19% of the 25 to 29 years old, and 22% of the 30 to 39 years old had received the second dose. Santé Publique France, 219. Indeed, it is only when the COVID passport was implemented that young people were incentivized to receive the vaccine. In this aspect, the study is not representative of young individuals. More specifically, before July 20, 2021, only individuals over the age of 60 had mostly received their second dose. The author's failure to address this representativeness issue and their implication that the study is representative of young people is extremely problematic. It would be interesting for AP FAIR to explain the choices they made. Why did they stop the data collection on July 20, effectively excluding approximately 80% of young individuals from the analysis without explicit mention? Young people are the category of the population for whom the benefits of vaccination cannot be demonstrated, since they neither die from COVID, nor develop serious health problems. Moreover, young athletes are the most susceptible to cardiovascular risks. These are two reasons to reiterate how important it is to analyze the consequences of vaccination on young people by looking at all-cause mortality after the injections. The AP-FAIR study does not provide information on post-vaccination risk, but only excess risk within the 3 weeks following the injection. The AP-FAIR study uses a peculiar methodology that does not allow to determine whether vaccination increases the risk of adverse events. In this methodology, the authors only check for excess risk of heart attack, stroke, pulmonary embolism, etc. within 3 weeks following a vaccination, first or second dose. A more classic approach for assessing post-vaccination risk would involve counting all adverse events, in this case, cardiovascular issues, occurring after the injection, and comparing this number to that observed for the unvaccinated, or for the same population before vaccination. In order to make these comparisons, it is necessary to standardize these events using the same population and time scales, for example, 1 week times patient. AP-FAIR makes a specific choice by deciding to only examine the excess risk during a 3-week period. Beyond the 3-week observation period, vaccinated individuals being monitored are moved into the control group, I.E. the group of initially unvaccinated individuals. The authors likely assume that cardiovascular problems occurring after 3 weeks are entirely unrelated to vaccination, and would have happened anyway, with or without the vaccine. This way, any cardiovascular problem occurring after 3 weeks will be counted in the control group. If vaccination were to increase the cardiovascular risk diseases in the medium term, beyond 3 weeks, the study makes it totally invisible. Furthermore, since an overwhelming majority of the study participants are elderly individuals who were fully vaccinated at the beginning of winter, an overwhelming majority of the control periods involve individuals who received the second dose more than 3 weeks earlier. However, we want to understand whether the vaccine increases cardiovascular risks in the short or medium term, not only within a 3-week window. If the number of cardiac arrests increases by 50% over the following months, this study would not be able to detect it. AP-FAIR provides a big clue that problems are being concealed. The Pfizer and Moderna vaccines indeed show sub-risks post-vaccination, the risks are less than 1. A quick or dishonest reading of the study would conclude that the vaccination protects against embolisms, strokes, or cardiac arrests. Obviously, such an absurd result can only show that problems happen mostly outside of the control period, in other words, after 3 weeks. With this method, the only possible result of the AP-FAIR study is that a vaccinated individual is just as likely to have a heart attack in the 3 weeks after vaccination as later. Why does the AP-FAIR study only consider the 3 weeks following the injections as a risk period? The group must justify this choice and conduct a comprehensive study over the entire post-vaccination period. AP-FAIR avoids looking at all-cause deaths this time again. AP-FAIR avoids looking at all-cause deaths post-vaccination. We had already noted this in their study touting the vaccine's effectiveness, and we are compelled to reiterate it regarding this one. By only taking into consideration cardiovascular events declared by hospitals, mainly among people over 60, AP-FAIR fails to investigate the possibility of under-reporting. For example, people could die alone at home, and with no one knowing whether they had a cardiovascular incident. Yet a simple way to assess whether vaccination has a positive impact on health and is innocuous involves examining every death reported to civil authorities by vaccination status. If vaccination is beneficial for health, one should easily find that the survival rate of the vaccinated is higher than that of the unvaccinated. Why has the Ministry of Health been refusing to conduct such a study all along, preferring instead to calculate complex ratios? Is there anything to hide? If vaccination is innocuous, all that is needed is to verify that there is no link between the date of vaccination and the date of death. To do so, one calculates the time passed between the vaccination and the death for all the individuals that have died in the past year, several 100,000 people. Then, one verifies that there are as many deaths at D+1, D+2 or D+100 after vaccination. Why does the ministry also refuse to carry out such a simple verification? Furthermore, AP FAIR has not released any statistics on the quality of the hospital data they used. The methodology report of the Ministry of Health on the matching between the database of tested individuals, CIDEP, and the database of vaccinated individuals, VAXI, shows up to 60% non-matches for older women. These people are then regarded as unvaccinated. In other words, for some age groups, an unvaccinated person is most often someone whose vaccination status is unknown. AP FAIR should be transparent on the quality of the databases it uses. Does the study really allow to tell the vaccinated apart from the unvaccinated? The study shows a greater risk with the Janssen and AstraZeneca vaccines despite all the methodological issues we have just highlighted. AP FAIR's study reveals an increased risk for the Janssen and AstraZeneca vaccines, a significant increase in the risk of heart attacks 2 weeks after the first injection for both vaccines, a significant increase in the risk of pulmonary embolism 2 weeks after the first injection for AstraZeneca. AP FAIR shows that these two vaccines are no safe. They do carry significant risks, and the French population was indeed used as guinea pigs. The French state is caught in the act of lying. AP FAIR's only defense is to claim that these vaccines are not widely used in France, which is a daring lack of respect towards the millions of people who were injected with these products. The government must address legitimate questions. Aren't these vaccines, in the end, unofficially banned today? Now that their harmful nature has been established, what is to be done for the victims and their families? Let's not forget France has graciously donated a significant number of these vaccines to poor countries. Countries through the COVAX Initiative 220. Isn't it cynical to dump unquestionably risky vaccines on these countries? According to the UN 221, each day, 25,000 people, including more than 10,000 children, die from hunger and related causes. Some 854 million people worldwide are estimated to be undernourished, and high food prices may drive another 100 million into poverty and hunger. Isn't there anything more urgent to do than sending syringes containing a product intended to protect people over 85 from a respiratory disease? In the end of the day, this AP FAIR study raises more questions than it provides answers. It is the second time the AP FAIR group has carefully chosen an arguable methodology. The first time was to overestimate vaccine efficacy, and now it's to downplay the post-vaccination harm. Not only has the impact on youth not been assessed, contrary to what the study's title suggests, but also the damages induced by adenovirus vaccines is clearly visible. What more evidence is needed to make the necessary decisions that have been required for several months? Link between vaccination and fertility. Where are the babies? In many countries that report monthly birth rates, a shortage of newborns has been observed since the start of 2022. The consistency of the data across different countries is astonishing. It seems as if women were affected by some illness around mid-2021, causing an impact on their fertility substantial enough to manifest itself in the birth statistics 9 months later. In a fictional scenario in which many women are injected with a substance harmful to their fertility, several phenomena should be observed. First of all, there would likely be a surge in births at the time of the injection of pregnant women due to preterm births 222. Prematurity is one of the leading causes of infant mortality. While there are no online statistics on prematurity, the examination of infant mortality can provide clues as to whether something abnormal happened at the time of delivery. Subsequently, once this peak of births has passed, disruptions in the menstruation of affected women, total or discontinuous cessation of menstruation or, conversely, abnormally heavy bleeding, would cause a collapse in the birth rate. These ill women would have lost their fertility. An extremely important indicator revealing major issues with a pharmaceutical product is the creation of victim support organizations. The collective Where Is My Cycle was created to document adverse effects on menstrual cycles following the COVID-19 vaccinations. Testimonies have poured in enough for the ANSM to acknowledge the problem. Statistically speaking, what is happening in 2022? Births in France and elsewhere in Europe. A break in the trend in C publishes the number of births per month in France, and it has been consistently decreasing for nearly 10 years. The aging of the population and the end of pro-natalist policies are instrumental in the declining number of births. Throughout the year, birth rates follow a seasonal cycle, with fewer births in winter and more in summer, figure 88. This regularity allows us to estimate the number of births expected each month, as a linear extension of the 2015 to 2019 downward trend. At the end of 2020, the number of births decreased significantly, likely due to the repercussions of the period of stress and lockdowns that took place 8 to 9 months earlier. From March 2021, the number of births started to rebound, clearly exceeding expectations. Several parents postponed their plans to conceive by a few months. The birth rate remained above the expected levels until April 2022. From July to December 2022, the birth rate dropped again, markedly falling below anticipated levels. Figure 88, average number of daily births and expected numbers. The COVID-19 crisis, including panic, disorganization, and the many measures put in place, has had a large number of detrimental effects on people's lives, as discussed at length earlier. In this chapter, we intend to measure its impact on births. The French birth rate has lost its regularity, and we are observing a significant decline in births. Our country is far from being an isolated case. Denmark 223, Germany 224, Switzerland 225 and Slovenia 226 also experienced a drop in their birth rate a few months after the lockdowns and mass vaccination campaigns. Unprecedented infant mortality in France in summer 2021. In France, the Vaccination Strategy Advisory Board declared pregnant women a priority target for vaccination from April 6, 2021. 227. Furthermore, young people started to get vaccinated in May 2021, a period when the COVID pass only applied to large gatherings. They then represented half of the vaccinated youth. The other half ended up accepting the vaccine when the COVID pass became much more coercive in July. Neonatal mortality 228, I.E. Deaths of infants under 4 weeks old, was analyzed by an anonymous citizen writing under the pseudonym of Christine McCoy. Her website 229 is entirely dedicated to examining mortality and vaccination data since the start of the COVID-19 crisis. Christine McCoy reveals that babies born in France in June 2021 have an exceptional mortality rate. For every 1,000 births, 4.6 babies born in June 2021 died during the year, compared to less than 3.8 usually. The excess mortality zone starts at 4.2 per 1,000 and the very high excess mortality at 4.5 per 1,000. This indicates a highly exceptional and significant event. A large proportion of these babies died within 6 days of birth. This is a very strong indicator of prematurity. The Scottish Institute of Statistics also provides information pointing to a particularly high neonatal mortality, I.E. outside the confidence interval, in September 2021 and March 2022. In addition, Scottish neonatal mortality remained above the average for 8 consecutive months, from March to October 2021, which is completely unusual. Similar events were recorded in Israel during the same periods. Neonatal mortality skyrocketed in the second quarter of 2021, just after the first vaccination campaign for young people of childbearing age, and in the fourth quarter of 2021, immediately following the campaign for the third dose, according to our WORLDINData.org 230.